Vedala, who is a specialist in obesity medicine. She is trained at Gandhi Medical College as part of her medical training. She came here to the United States and did her residency at St. Joe's Hospital in Michigan. She's based at Herman Memorial Hospital as an internist, outpatient care, and has done a specialization in obesity medicine, which she practices as part of a collaboration with the University of Texas, Houston, and with Herman Memorial Hospital. Again, she's been very kind to give these talks to at multiple venues, and I thought this would be a very special place to share her talk. So again, please take it away, Maitli. Thank you so much for joining us and giving us this talk today.
Thank you, Radhika.
Okay.
Maitli, did you unmute? Yeah, thank you.
Yes. Thank you everyone for your time, and thanks Linda and Radhika for the opportunity. I definitely, this is a topic that I'm very passionate about, and I will talk about heart disease and how obesity links with heart disease and the risk factors, etc., associated with it. And management, of course, how do we manage the chronic diseases of both heart disease and obesity? Let me, Soma.
She's muted.
Yeah, I'm not sure what buttons I'm pressing, but
I think she's trying to talk to my daughter while she's muted. That's why. Tech support.
yeah, I know. They don't teach that at medical school, so I'm not sure the up and down not going through. I think I just have to move it.
Soumya, there's a mouse in my office. If you want to share that, that might make it easier.
We got it. Okay. So these are the objectives and the introduction, and we will discuss some of the risk factors of obesity and the development of heart disease, mortality associated with the two chronic conditions, and the impact of weight loss on cardiovascular disease outcomes, approaching and managing this disease, especially heart disease, in people who are overweight and obese. Options for treatment. We have a program, as Dr. Bookputnam had mentioned, with the University of Texas Health in Houston, which is called the Memorial Hermann New Start program. It is a collaborative program that we started about a year ago, which offers both medical and surgical options for weight management. And I am part of the medical weight management arm of this program. So then moving forward, we will discuss some of the lifestyle tools and strategies in managing this disease. So obesity, as we know, is a chronic health condition. It impacts many, many different organs from head to toe. Our focus today is primarily on heart disease, and hence the ones that are highlighted are the ones that we will focus on. Some of the ones, specifically the cardiovascular disease, include dyslipidemia or high cholesterol, high blood pressure, cardiomyopathy, chronic inflammation, where obesity actually impacts the stickiness and endothelial function within the blood vessels, as you can see that is highlighted there. Type 2 diabetes, which is very much prevalent in people who have the disease of obesity, is a significant and a great risk, one of the major risk factors for heart disease, as is obstructive sleep apnea. So although there are multiple other organs that are impacted by the chronic disease of obesity, we are going to focus on some of these since we are focusing on heart disease today. This slide only goes to show that some of these chronic conditions which have a direct impact on heart disease also are very much prevalent in people who are obese. So these are just numbers here that I have on the slide. It just in order to summarize and make sure we have time for questions, I'm going to slide through some of these screens quickly so we have time for ample time for questions. I thought this slide was interesting. This is a slide from Center for Disease Control, the CDC. Even though an old slide, as you can see, we have on this slide, the data is up until 2013. If you follow the trend, the slide basically summarizes that as with time, the map only gets darker, which means as the prevalence of obesity increases, the prevalence of type 2 diabetes also increases. And so you can see how the two maps almost mimic each other. It's interesting to say in the state of California, in the year 2013, it was still orange, which was, less than the greatest number of people with diabetes and obesity. But as you can see, it is, again, in 2013, it seems to have darkened. At least the patients with type 2 diabetes have definitely increased. However, the number of people with obesity are not as many as you can see in some of the southern, Midwest, and northeastern states. This slide goes to show this. This is a correlation between body mass index and the various chronic diseases which have a direct impact on heart disease. The blue bar indicates underweight, red is normal, people with who are considered within a normal BMI, which is 25 and below. Green is a body mass index of 27 and below. Well, actually 25 to 27. And the purple bar is indicative of a body mass index greater than 30, which is one of the definitions of obesity. So if we were to look at the bar graphs and correlate with body mass index, this slide goes to show that greater the body mass index, as you can see in the purple bars, the greater the incidence of diabetes, cholesterol, and hypertension. So people with higher BMIs have a greater tendency to have all of these chronic diseases, either one, two, or all of them. And of course, they increase risk for heart disease as well. These are the myriad of cardiovascular effects of obesity. Specifically, again, some of these are, some of the medical jargon may be, it may not be appropriate for maybe just too much for the audience, but I'm going to skip through. I'm going to go through the ones that I think will be pertinent. One is left ventricular hypertrophy or thickening of the left ventricular. Again, this is based on studies and various tests that have been performed on individuals with greater BMIs and obesity, where tests have correlated to some of these conditions that have directly impacted their heart health. So left ventricular hypertrophy can occur in patients with high blood pressure or hypertension. Congestive heart failure, we are all very well aware of this situation. Arrhythmias and AFib, again, the point that we are trying to make is people with greater BMIs or people who are obese with BMIs greater than 30, the risk of having these specific cardiovascular conditions is definitely greater than the average population. The impacts on arterial disease, angina, and myocardial infarction, which is a heart attack or lack of blood supply to the heart blood vessels. Stroke, which is lack of blood supply to blood vessels in the brain. peripheral arterial disease, which is blockages in blood vessels in your arms, legs, again, which can be, which we do see in individuals who have type 2 diabetes or hypertension or high cholesterol, along with smoking, family history, etc. Venous disease, deep vein thrombosis or blood clots in the legs, which can lead to a blood clot in the lung, which we know is can be a fatal condition. So individuals with greater BMIs are at a higher risk of developing blood clots, not only in the arterial blood vessels, but also in the venous. So we do want to make sure that our audience is made aware that having deep vein thrombosis or blood clots in the leg is very common or not uncommon in individuals who are obese. I am going to move to the next slide. This is just another study that came out, which showed that there was a direct impact of obesity on heart failure, and this was independent of some of the metabolic risk factors that lead to heart disease, such as high blood pressure, cholesterol. So heart failure was an independent, obesity was an independent heart risk for heart failure without individuals even developing either hypertension or diabetes or high cholesterol. So I just wanted to mention that. This is just a slide that again indicates the various metabolic changes that can occur with obesity, which again may lead to heart failure. So it is an independent risk factor, but some of these patients also tend to have these other risk factors such as high cholesterol, insulin resistance, hyperglycemia, or type 2 diabetes, and hypertension. And 1, 2, or 3 or all of these risk factors individually or in combination with each other increase the risk of development of heart failure. So just a quick summary of how obesity and what we see in individuals who have obesity and the increase in incidence of cardiovascular disease risk. So as mentioned in the previous slides, obesity is associated with a high cardiovascular risk and premature cardiovascular mortality. It is because it is associated with the development of metabolic risk factors, such as development of high blood pressure, high cholesterol, and diabetes, as previously seen. Higher the BMI or the greater the BMI, the incidence of these metabolic risk factors is greater in those individuals, leading to development of heart disease. It also has, as we mentioned, a unique independent association with development of heart failure. So when we will discuss the treatment and management of obesity, but I just wanted to put forth what and how much are we looking for and how much will make an impact on the progression of heart disease. And so if we were to look at diabetes, a 5-kilogram weight loss, which is about 11 to 12 pounds, decreases the incidence of heart disease by 30 to 60%. So I think that is a significant change in the incidence of heart disease with perhaps lifestyle changes, with medication if indicated. And then 5 to 10% body weight loss decreases the A1C by almost 1%, which again is quite significant. And so on and so forth with the lipids and blood pressure. Again, a change, we're looking between 7 to 10 pounds. If you're looking at 3 kilos of weight loss, decreases your triglyceride reduction, which again directly impacts your heart health. And about 10 to 14 pounds of weight loss will decrease the HDL and increase your HDL, which your cardiologist will be very happy with if we were to move in that direction. So again, stating the fact that moderate weight loss, we are not looking at 60, 70, 100 pounds of weight loss, but moderate weight loss of 5 to 10% improves cardiovascular risk factors, hence reducing risk of having cardiovascular events. And marked weight loss, which is 10% and above, definitely has shown, and there are many trials And studies that are ongoing in this field have significantly improved mortality, and there is data to support this. So we will move forward with how do we assess and how do we treat, and then go from there. Any questions so far that the audience may have that would like to ask? Okay, no questions. I'm going to move forward. We'll definitely have questions at the end. So when we talk about the approach to patients who have higher BMI or the chronic disease of obesity, how do we approach the patient? How do we measure the risk, and how do we address it? So that's the next few slides that I will be focusing on. So our approach is holistic, patient-centered, and we feel that all of the various metabolic risk factors need to be addressed in order to mitigate the progression of these conditions, which may impact cardiovascular health. So one easy mnemonic to remember is A, B, C, D, and E. This is more for the providers or the physicians or the caregivers who, not caregivers, but healthcare providers who are going to be initiating the process when they see a patient in clinic. Risk assessment, addressing obesity as a risk factor, extremely important. Addressing blood pressure if present, cholesterol if present, diabetes and diet, as well as exercise. We're going to go through each of these alphabets in order and see how they impact health. So for risk assessment, when you go into the doctor's office, this is often done. One is checking your body mass index. That's really mostly a calculation based on your height and weight, or body surface area, and it gives us numbers such as 25, 37, 42, and then you may see in your chart obesity grade 1 or grade 3 or grade 4 or overweight or normal weight. So this is one of the measurements that is used to determine how aggressive do we need to be in terms of making lifestyle changes and or adding medications to help reduce the metabolic risk factors that lead to heart disease. So, so in addition to the body mass index, some of the other criteria that are used in various clinics, we certainly use this in our clinic, is the waist circumference. As we know, there is definitely a known correlation between waist circumference and heart disease. The measurements on this slide are in centimeters, but if we were to translate that into inches, this is 88 centimeters in women, which translates to 34 inches, and 102 centimeters in men, which translates to about 40 inches. So that is another criteria that can be used in terms of assessing, which is the A part of the ABCDE that we will be talking. And this is again primarily what we do in our clinics in order to stage or grade and see how aggressive we need to be with treatment. Many of us also use a risk score, and your physicians in clinic may share this with you. It's the atherosclerotic cardiovascular disease risk, which is again a measurement based on age, ethnicity, presence of high cholesterol and numbers as such. And based on that, a risk stratification with a percentage is provided, which again gives us information as to how aggressive we need to be in treatment of the condition that may lead to cardiovascular disease. Again, addressing blood pressure, cholesterol, and diabetes individually during the visit is extremely important. First of all, assessing if you do have hypertension or high cholesterol or diabetes, and then addressing each of these conditions separately, whether it be just lifestyle changes or medications, along with lifestyle changes that need to be addressed. as previously mentioned, 3 to 5%, which is considered to be moderate weight loss, has shown to improve measurements of blood pressure, cholesterol, and blood sugar. I'm going to skip this slide and go to the next slide, focus a little bit on diet and exercise, which is the D and E part of the A, B, C, D, E that we previously mentioned in management of obesity and heart disease. So diet, I'm sure, being in the location where you're at and all the information that is shared, you can probably tell me more about the different types of diet that are helpful for heart health. Then I may tell you, you are very much familiar, I'm assuming, with the Mediterranean diet, the DASH diets, etc., for hypertension, etc. And of course, as your classes may have mentioned in the past, whole grains, fruits, vegetables, lean meats, legumes, nuts, moderate alcohol. I mean, this is like I said, I think you can probably tell me more about nutrition and heart health than I can tell you in this one slide. Exercise, 150 minutes. The current guidelines, these haven't changed for a long time, and I wish they would, because we kind of underestimate the importance of exercise, which again, with cardiac rehab, that is one of the vital parts of your progress with heart health and progress and maintenance. So I think it is an extremely vital part of the lifestyle change that is important for heart health. And currently, the guidelines continue to state 150 minutes of moderate to vigorous exercise a week. And for weight loss maintenance, after you reach a certain goal, which would be based on probably a 6-month mark from start of consistent habits, the amount of exercise that needs to be done in terms of minutes is actually greater than what is needed for weight loss. So per guidelines, current guidelines, even though not mentioned on this slide, 150 minutes of moderate to vigorous exercise per week for weight loss, and about 200 minutes for maintenance of weight. So we actually have to work harder in order for us to maintain weight loss, as opposed to the amount of exercise or the time we spend in exercising when we are in our journey towards losing that weight. Now, in addition to diet and exercise, in our clinic, we focus quite a bit on behavioral health, counseling. The impact of self-monitoring using various tools, and we will, I'll be talking about that on the next slide. Again, to facilitate or in order for the individuals who are on their journey towards weight loss to adhere to the diet and the exercise plan. So how do we stay accountable? How do we keep up with it? You've lost 20, 30, 40 pounds. But in order for you to not gain that weight back, what are some of the tools that you could use to continue your journey? And then, in our clinic, we see many patients with BMIs that are requiring more than just a lifestyle plan. And so that's where we step in and we try to create an integrated multidisciplinary weight management program, which includes a dietitian. We do prescribe medications safely and only if needed, according to guidelines, to help individuals manage their weight. This slide again talks about some of the things we just talked about, the moderate to intensity workout or exercise per week, and then just increasing it to, it says 300 minutes. If we were to do the moderate, sorry, I take that back. So adults should do 150 minutes to 300 a week. 150 is the minimum and 300 is bonus. So it's up to you as to how much you would like to do. And this is focusing on cardio. In addition to cardio, there are also recommendations in terms of muscle strengthening, 2 or more days of the week, which is recommended. And again, this is for weight loss as well as for weight maintenance. This again is a lot of medical jargon with the various impacts of physical activity and how it positively impacts your heart health. Now, I had mentioned some of the tools that we had talked about, and these are tools that are now widely available. You can purchase them at Walmart. You can get a biometric scale. A biometric scale is a scale that gives you measurements of body fat mass, muscle, and water, and the changes over time as you move forward in your weight loss journey, which is again, which tells you, hey, you lost weight, but you lost muscle. So how do you keep up with your with that? So again, just gives you a measurement, and of course, if you have concerns, you can speak to your healthcare provider about that. You can check your weight, which is another way to just monitor how far you've made through your journey. A waist circumference, like we had previously talked about, 34 inches in women and 40 inches in men is currently the diagnostic parameter for obesity. So we are looking for, or we would like for our patients to have a goal of less than those measurements in order to, again, mitigate some of those metabolic risk factors which lead to heart disease. Activity tracking, again, I'm sure you're very well aware of this. There are various apps and watches and phones and devices that help you track in terms of what you would like to track, whether it's just your steps, your sleep, your heart rate, or your blood pressure. So again, it's important because we're trying to tie this all in together. How does moderate amount of weight loss impact your heart health? So as you continue to lose weight, all of these other parameters, such as your blood pressure, your pulse rate, etc., will improve. And that will be useful information, not just for you, but also for your physician who is managing your blood pressure or your sleep, etc. There are apps for logging food intake. Again, in as many articles that we've gone through in the past, just in terms of weight loss and maintenance. If you're comfortable tracking and logging your food, there are multiple apps. These are the most commonly used ones, which is MyFitnessPal and Lose It. There is a free version of each one of those, which at least enables you to track your macros, track your steps, and you could share them with your provider if they're interested. We certainly track them in our clinic along with our dietitian. Again, really helps us to track our patients in terms of are you getting enough of your macros with your diet? As you lose weight, you lose a lot of fat mass, but you could also lose your muscle mass. And if you're not keeping up with your protein intake, those measurements will change. And so when patients track, one, they're mindful about what they are eating, and two, we guide them towards what ratio they should be, eating their macros. That's primarily with the dietitian, who does most of the tracking and supports our patient in terms of their questions, in terms of managing their macros. So moving forward, so these are some of the technologies. These are pretty simple, available everywhere. I mean, a simple weighing machine, if you do not want to do a biometric scale, just a scale to measure, where you are with your weight. Now, this being a cardiac rehab, there are individuals who may have heart failure. And so having that and checking a weight is extremely important, as your cardiologist will track and monitor. So that, in addition to, so fluid weight is different, and the amount of weight that you gain with that you gain is different from fluid weight. So it'll be important to know the difference and how to manage. Planning meals is, again, another tool. Just making time, maybe 30 minutes over a weekend or during the week, setting some time aside to say, what can I do for the week? What is my breakfast, lunch, dinner, and snack going to be? Who in the household is going to be doing the shopping? So having a plan in place is always helpful. That means you're actively and mindfully thinking about what should be done for this week, so that you just don't end up in the grocery store and then you're picking up all the, we ask you to stay in the periphery of the grocery store and not really go into the aisles as much if you can avoid it, because that's where most of the processed food lives. So if we can avoid that and focus on the fresh fruits, vegetables, and meat options that are available, and trying to stay just around the periphery while you do the shopping. Again, having that plan in place and say, okay, today I'm just going to focus on getting my meals prepped and see if I can get the fresh groceries and avoid the processed foods would be helpful. It's always nice to have a support or a buddy or a partner that is willing to do with you, willing to do this with you. Again, for you being part of cardiac rehab, you often meet people who have similar health and lifestyle goals, and so that's a great place to be at, because you're all striving towards reaching those health goals and keep each other motivated to move forward in this journey. And then the journey is not just weight loss, but the journey is really towards health. So whether it be your cardiovascular, your heart health, your cholesterol health, your diabetes health, I think all of that is greatly impacted by the lifestyle changes that you make. So having a partner always keeps you motivated in this journey. We encourage our patients to share their success. What are you doing that is helping you? And, as we get closer to the end of this presentation, it'll be helpful if you want to share some of the things that you have done so far that might interest and maybe help some of the other individuals who are on the presentation to see maybe it worked for them and maybe it'll work for me if I were to do the same thing. So success builds success. So your stories that you share will definitely motivate others. So this is again part of what we do. I'm going to change gears just a little bit. This is part of the management of medical weight loss. I'm not sure how much you're aware of all of the information that is now available on social media as well as in the news with the GLP-1s, the new Ozempics, the Mounjaros, the weight loss shots, and buy one and get the second month free, and all of that. That's been out for about a year. Medications need to be prescribed by a prescriber who knows what they're doing and prescribed to individuals who fit the criteria. And so our goal here is do no harm. So just make sure we screen those patients carefully. We do prescribe medications to help with weight management, but that only comes after lifestyle changes. So, and then established goals of treatment. So this is part of what we do, but with extreme caution, knowing that there are side effects and other impacts of these medications if used for a period of time. In our center, because we are a weight management center, we do work with bariatric surgery providers in the area, and the guidelines for bariatric surgery, which are primarily the gastric sleeve and gastric bypass. Gastric sleeve is the most commonly performed bariatric procedure. I think it's about 90% at this point in the state of Texas. And then in the gastric banding is not done anymore. It was a procedure of choice maybe 15 to 20 years ago, but but there were too many complications and long-term implications associated with it. So many surgeons at this time, bariatric surgeons, in fact, remove gastric bands, and no new gastric bands are being placed because they're against the guidelines for bariatrics. The guidelines, again, as you can see, the current guidelines, even though stated here, is BMI greater than 40 and BMI greater than 35. The most recent guidelines, the body mass index has actually shifted to 30 and 35. So which is if an individual has a body mass index of 35 with no other comorbid conditions such as hypertension, diabetes, or sleep apnea, then the body mass index in itself will qualify them. Of course, this is all per insurance guidelines that we unfortunately have to follow. So they will qualify for bariatric surgery. And then the body mass index of 30 with a comorbid condition that I just mentioned will again qualify them per insurance for bariatric surgery. Again, all of this is after they've gone through lifestyle medications or a combination of treatments and have not been successful at it. Bariatric surgery is an option for these individuals. So again, in summary, obesity is strongly associated with development of multiple risk factors, which lead multiple risk factors for heart disease. Unique association between obesity as an independent risk factor for heart failure. We discussed the benefits of modest weight loss on risk factors that lead to decrease in cardiovascular disease and mortality. And then the need for a comprehensive patient-centered approach for addressing cardiovascular disease in patients with excess weight. I feel that this is definitely a field or an area that lacks a lot of support, or I feel that this is not much talked about, even among physicians. We only have 15 to 30 minutes based on the kind of visit to discuss blood pressure, diabetes, cholesterol, updates from any hospital visits, and then to discuss weight is another 30 minutes if we were to do it in a comprehensive manner. So this is an ongoing subject and topic where we are trying to expand physicians who can primarily focus on these, physicians with the expertise who can primarily focus on a patient-centered approach where they can give them guidelines and help and support with regards to weight management. I do recognize that the cardiac rehab where you are at does a lot of this. I mean, from what I've known and I've continued to hear from Dr. Bookpatnam, that there is focus on lifestyle changes is definitely an ongoing endeavor, and that continues, which I think is a major part of management of cardiovascular disease. I'm going to skip this slide. And again, this is summarizing keys for success. Weight loss is a journey. It is not a goal to have just for a wedding or fitting into a new dress or, for an event. I mean, that is a good goal to have as long as you can continue to keep at it with maintenance of your weight. Always remember why. What is your motivation? Why would you like to continue down the journey of losing weight and maintaining it? Build on your previous successes. If you did Weight Watchers, or you were at cardiac rehab, or you did Nutrisystem or Optavia, where or you saw a physician and you felt like that was a successful process for you, reach out to them and see if you can do it again. A support system, as we mentioned, doing it with a partner or a buddy, always encourages you to keep at it if they are available and willing to move forward with you in this journey. Self-monitoring, as we had discussed, logging your foods, weighing in at home, tracking your activity, sleep, etc., will also encourage you to keep going. So with that, I will take any questions and go from there. Thank you for your time.
No, thank you. I do have a question. You alluded to taking more minutes to maintain your weight loss than it does to lose it. So can you talk about that a little bit more? You said 200 minutes versus 150.
Yeah, that was interesting when I was going through the slides and trying to do some prep. For some other presentations that we've done in the past, is when you lost in your weight loss journey, if you started at if the individual started at perhaps 200 pounds and they lost about 25 or 30 pounds and they were able to keep the 150 minutes a week, if they had reached their goal, and the goal is based not on what they want, but we have what's called, the body has a set point, and beyond that you won't be able to, based on your age, based on your other health and risk factors, your body will kind of settle at what's called a set point with weight. And if the individual who was on this journey had lost about 30 pounds from 200 to 170 with 150 minutes consistently, along with other lifestyle changes plus minus medication, if they were to maintain, if their body's set point is at 170, and if they were to maintain that, the studies have shown that they actually have to keep up with a slight increase in the number of minutes. It could be the same type of exercise, but they really have to work a little bit harder, honestly, to maintain that. Why does it happen? I do not have the physiology and the background in terms of why. As we know, when you lose weight, there's a lot of changes to your muscle mass and to the fat mass, and the ratios change. And so it doesn't take much to switch that back again, where you will, gain more of the fat mass if you were to stop exercising. And so the minutes are currently based on previous studies, but I don't have any more than, why does that happen or why should I? It's just that based on, I think I skipped a slide, but I think that slide did show that maintenance of weight was a little bit more difficult than the losing, and exercise was the biggest part of the equation for that.
Interesting.
Yeah.
And what can you share about your success for your program, your clinic?
Yeah, so, I've been doing medical weight management in my primary care practice. So I primarily do, I'm internal medicine. So currently 30% of my practice is medical weight management. I've been doing it for about 8 to 9 years, certified in that. So, when I was in a practice, I felt like just doing it as part of primary care was challenging. As mentioned, we get 15 minutes for a follow-up visit and 30 minutes for a new patient, where you're addressing 6 different things and trying to, help the patient. So I would schedule these appointments separately and actually do a weight management visit for these patients. So as time went by, the patient population and the number of patients in my practice increased, and belonging, I do belong to a health system. So we partnered with UT, which is University of Texas. We are in different locations. So we just opened a practice in the Woodlands, Texas, which is only dedicated to weight management. We have a full-time nurse practitioner. She's there all 5 days. And then we have a dietitian who is there, and we have some equipment, again, to monitor the progress of weight management. So we do get referrals from our cardiology colleagues. We get referrals from our gynecology colleagues. We have a lot of patients who deal with infertility or PCOS, where, again, weight loss does help get them pregnant, or, weight loss does help them with their lifestyle goals. We get referrals from our orthopedic physicians. So currently in our health system, the body mass index of greater than 45 is considered as a major risk factor for any kind of surgery. So if it's an elective hip surgery or knee surgery, that surgery will be delayed. Of course, these are elective surgeries, so they are not done or delayed unless the patient can reach a goal BMI less than 40, 42 is what I think our surgeons are looking for. I mean, we do understand and recognize the risk of anesthesia and healing after surgery, and the risks are pretty significant if the BMI is greater than 45. So we get referrals from endocrinology. They don't want to do weight management. So they send patients with diabetes and various other endocrinological issues to us. We also get referrals from our GI colleagues. Fatty liver, if you've heard about that condition, I'm sure you have. Hepatic steatosis and non-alcoholic fatty liver disease is, in fact, the #1 reason for liver transplants currently. And one of the major risk factors for NASH or non-alcoholic liver disease is obesity. So again, helping these patients recognize when they are in the stage of steatosis, before it progresses to fibrosis and cirrhosis is important. If we work with them, we have seen reversal of that condition to, or at least maintenance of that condition to steatosis. So we are a growing practice, and we continue to hope to support our patients in the future.
And you're on the medical side, you said, so there's probably more medical management, especially with the newer drugs, than the surgical people, right?
Yes, the medical management aspect or arm of this team only does the medical part of it, and the medical management providers are the only ones prescribing medications. The surgeons do not prescribe it. But I do, even though this is not, I'm going to deviate just a little bit on that topic. So there was a new study, it's called a SELECT trial on the use of GLP-1s, specifically a semaglutide called Wegovy. I don't know if you've heard about that. It's a new the medication isn't new, but the study is new and was recently presented at the American Heart Association, the meeting that was held in November, I believe, and presented as a drug that it could lower the cardiovascular risk and mortality by 20%. So individuals who were obese and non-diabetic, who were prescribed this medication and were able to get up to their maintenance doses, the risk of, it was able to lower the risk of cardiovascular disease by 20%. This was the SELECT trial. So there is a lot of buzz among cardiologists and, the Novo Nordisk, which is a company that makes the medication, and us as weight management physicians. And we will be seeing more and more cardiologists prescribing, I think, the medication. But I only hope they can help with the maintenance and support on top of everything else that they do for our patients. There is some talk about them starting to prescribe. I know that some physicians are starting, some cardiologists are starting to prescribe that medication, but we'd be happy to work with them on this. But this is a trial that was just, that came out a few months ago and has shown a significant impact on heart health.
And are these medications affordable? Or are they expensive?
Great question. So,
Why are you laughing, Radhika? What?
They're not. They're not, and they're not available. That's the other problem.
So, the market for this has exploded in the past year to year and a half. I really don't blame the patient as much for this as I would probably lay the onus of over-prescribing or over-prescriptive behaviors on the physician. I mean, if a patient comes to you with a BMI of 25 or 24, it's really not an appropriate prescription to be given to that patient. So it's really important that a physician knows who they're prescribing to and what it is being prescribed for, and not really, I want to get ready for my wedding and can you give me this prescription, right? So it's really, so I think on account of that and and how popular these medications have become, the number of prescriptions that have gone out in the past year and a half have significantly increased. In fact, if you are aware, the rate of bariatric surgeries has dropped nationwide by about 25 to 30% since the semaglutides have been on the market.
Yeah, that makes
These
sense.
medications, Medicare does not cover for them. Medicare will not, at least as of now, is not covering for them. These are for individuals who do not have diabetes. So if not covered by insurance, they are about $1,000 a month for 4 shots.
Mhm.
Yeah, so they're expensive. If covered by insurance, it can go as, it would be as low as $25 copay for the month. There are some companies or health systems that recognize obesity as a chronic health disease and do support the need for these medications. And I'm thankful that our health system currently is one of those which is supportive, but I just don't know when that will change, just because of the cost involved in the care of these patients and the cost involved in the because of how expensive these medications are. But again, if correctly prescribed to the right patient population, I think there is a significant benefit, because you're not only reducing the risk of developing diabetes, blood pressure, cholesterol, etc., but overall you're improving their health, which can lead to their cardiovascular issues, heart disease, heart attack, stroke, etc. So work in progress.
Yeah, interesting. Anybody else have questions?
I saw a passing reference to metabolic syndrome in the slides. And I remember when I went through my orientation in rehab, the first lecture, Dr. Capagoda has spent more than a handful of slides on metabolic syndrome, what it was, part of steering you towards a lifestyle change rather than an episodic event where you do this and you're all better and you can go on living your life. And since there was just a short reference here, is that a passing term, or is that something that still exists and it just occupies more time than you could give it to this?
That is absolutely right. If I were to do a presentation, it would take a whole presentation on metabolic syndrome for us to talk about that, as your physicians have alluded to in your previous comment that you made, that they spent a lot of time talking about it. So metabolic syndrome, yeah, I mean, we can talk, and like I said, we can do a whole presentation. It is still a diagnosis that is used and talked about a lot. It is a compendium, it is a compendium, or it is a combination of many different conditions, again, metabolic conditions, which is why it's called metabolic syndrome. And these include waist circumference, they include blood sugar or insulin resistance or pre-diabetes. It includes your
Low HDL.
triglyceride and low HDL numbers. It includes your diastolic blood pressure. It also includes your, in women, it actually also includes PCOS, which is polycystic ovarian syndrome. So if you were to have 3 of the 6 or 7 conditions listed, the individual is diagnosed as metabolic syndrome, and your physicians are right. It is a lot of it is lifestyle changes. And again, if you see, these metabolic risk factors are major risk factors for cardiovascular disease. So if lifestyle changes were made, metabolic syndrome was treated as such, that would certainly reduce the risk of heart disease for that individual. So there's a whole slide in terms of specific numbers and for blood pressure, cholesterol, blood sugar. What are we looking for? What are we aiming for? It used to be called Syndrome X, which I suspect no one knew what it was at a time. I think that was perhaps in the 80s and 90s, but then that has evolved into metabolic syndrome, which is a code that, you know, we put for many of our patients that we see in our clinic, because it is not difficult to find a patient who has high diastolic blood pressure, high triglycerides, a waist circumference over 40 for male and 34 for female. And those 3 criteria in itself are predictive of metabolic syndrome and increased risk of having heart disease, et cetera. So, and then the conversation starts from there as to, this is your risk, and, you know, how do we move forward from here? Does that answer your question, sir? Yes, but sorry, I couldn't spend much time on that. It is a whole presentation itself. That's a good question. I get that question asked all the time in every presentation I give, so.
That was an excellent presentation. Thank you so much. What do you think about intermittent fasting as a way for weight reduction and maintenance?
Great question. So intermittent fasting, there are various ways of doing it. There is, and it is one of the tools that can be used by individuals to help with their weight loss journey. There is a 16-8 fast, which many of our patients do, which is 16 hours of fasting and 8 hours of eating. This pretty much is changing the number of hours that you're eating, right? So that helps you kind of focus. It's more of a mindful eating. It's a mindset thing where you're like, at 8 p.m., I'm going to stop eating. You know, there is, well, in our practice, or, you know, we see that all the time, you know, 8 p.m., it's the end of dinner, and then we start watching TV, or, you know, we're just talking to family. And so that's the time the snacks come out and the ice cream comes out, and then the alcohol or the wine, or, you know, it's a time to relax. So one of the advantages to doing intermittent fasting is you have a set time. You got to get everything done within that time. So it really helps some of our patients stop that nighttime eating and snacking, because between the times of 8 to 12, if you are strictly following your fasting, you are not going to be eating. What is included, what you can do during that time is beverages that do not carry any calories. So you can drink coffee without sugar and cream, or tea, or you can drink water. and that is not included in your fasting. So 16-8 is a common one that many of our patients do. The other one that's a little less intense is the 10-14. And again, it's all consistency. If this can be done consistently, not just 3 days a week or 4 days a week, it has shown to help with weight loss as well as weight maintenance. It does change the way your body processes your insulin and your metabolism. So, you know, it says, okay, you have 8 hours and you got to get all your macros in. So if you're focused on weight loss, you know, the 8 hours that you can eat doesn't mean you reach out for a bag of chips or popcorn and sweets and candy. You know, in those 8 hours, you're trying to focus on getting your macros and, you know, maybe working with a dietitian or a physician, trying to make sure what you eat in those 8 hours is the quality of food and not the quantity of food. So many of our patients do that, diabetic, non-diabetic. I think it helps with both of those situations. Good question. We get asked that question all the time about 8, 16, 10, 14, whatever suits your schedule.
Any other questions?
Excellent. I hope that wasn't boring, but again, it really boils down to lifestyle.
Linda, any questions online? So sorry, just before we call off, I want to make sure that anybody online that has questions is addressed.
Of course.
There is no questions here right now.
Okay, excellent.
Thank you
Sorry,
so
go
much.
ahead.
It was wonderful.
Well, thank you for your attention and thank you for your time and have a good rest.
You.
Thank you.
Thank you. Thank you very much. Thank you for the wonderful presentation. Thank you.
Bye-bye.